I see Rana nodding. So welcome everyone to the Echo today. As we begin, there are no disclosures, no financial arrangements related to the contents of this activity. For many of us in the Hub team, either in the past or currently in the present. And the talk today really is, about how to assessment and screening for substance use disorders. And the objectives are, we're really going to start with the importance of screening for substance use disorders and co-occurring psychiatric illnesses in a primary care setting, especially. And we're going to go into some recommended models for screening and assessment. And then we're going to review some common screening tools that can be used in primary care and specialty screening. So as we begin, really, the point is that, substance use disorders are, as we've all been hearing, unfortunately, quite common, right? This is slightly older SAMHSA data, but unfortunately, the rates have remained high. And particularly, as we often talk about in these sessions over the last couple of years, as the COVID pandemic has raged, we've actually seen a lot of the sort of the data around substance use disorders worsen right here in New Mexico and around the country. I think I'm sure many of you guys just saw the recently released data that over the year, the data that was released by the CDC showing that after the start of the COVID pandemic, the United States as a whole recorded some of the highest overdose-related mortalities ever in the recorded history period. Right, in New Mexico, we've seen opioid-related overdoses rise, close to 30%, somewhere between 25 and 30%. And alcohol, right? We often forget about that, but alcohol is extremely common, in our adults as well as in youth. So I think substance use rates are quite high. But at the same time, and again, this is something that has remained unfortunately true, that access to specialty addiction treatment, specialized treatment for substance use disorders is unfortunately all too difficult to come by, right? So again, as this shows, right, only about 10 or 11% of those who need treatment for substance use disorders, SUDs, of course, standing for substance use disorder, actually are able to receive specialty treatment, right? So vast majority, about 90% of individuals who could benefit from treatment are not even able to access specialized substance use disorders treatment. And I think there are many reasons for that, right? Stigma certainly plays a role in it, something we talk a lot about, where people may be reluctant to seek that treatment, right, because of stigma, but also things like cost, lack of interest, and lack of availability and lack of access, something that's particularly prudent in rural parts of our country, rural and frontier areas, where specialty substance use disorders treatment can just be really difficult to access, right? We see that all the time in the cases that get presented in our ECHO, where, we can give all kinds of wonderful recommendations, but if the patient is not able to access them, right, those remain just recommendations and unfortunately don't necessarily benefit the patients. But on the other hand, primary care is much more common, right? So a majority of adults and even more children, pediatric patients, see a healthcare professional, in any given year, with majority being primary care visits. Secondarily, another common thing that people access for healthcare is emergency department visits, right? And I think maybe that's in a way sort of reflects the gaps in our care, where many people wind up turning to the emergency department for things that may be better handled in less intensive settings. But emergency departments often serve as the safety net for many individuals, right? So I think therein lies the opportunity that these general medical settings, whether we're talking about primary care clinics, which is kind of the first thing, or secondarily emergency departments or urgent care settings, right? Because more people are accessing them, they're coming into contact with more individuals who are not otherwise accessing specialty substance use disorders treatment. That's the opportunity that we can, if we're doing a better job screening, then we can better connect with these individuals who may have substance use disorder, who may never go see a specialty addictions clinic, or those with milder substance use disorders or milder problems, hazardous drinking, for example, who don't necessarily require specialty treatment and can just benefit from having their illness addressed and treated through a primary care setting. In fact, and I think it's important to point out that according to U.S. PSTF Preventive Services Task Force, universal screening in adults for substance use disorders in primary care settings is now recommended, right? That is one of the recommendations, so we all should be doing it. So I think that adds maybe some extra value to this presentation. So it's an opportunity. It should be done according to US PSTF, but how do we best do it? How do we best reach these patients, right? And that's where screening and assessment come in. Screening and assessment are what help providers understand what the patient's needs may be, and then allow us to match them to the right level of services to meet those needs. And also, as we work with our patients over time, it allows providers, clinicians to track symptoms over time and to adjust treatment accordingly to make sure patients are receiving the right level of treatment. With that, I believe, Dr. Maley, I'm gonna turn it over to you. And if you want, I can just manage the slides, or if you prefer, you can.
Yeah, if you want to unshare, I can pick up where you left off. I have the slides. Then I don't have to bug you to constantly change the slides.
Thank you.
Great, just give me 1 second to switch over. Okay. So hopefully everybody can see these. So what I'm going to try to do in about 15 minutes is cover a general overview of screening and assessment, talk about some global assessment strategies and where screening fits in, and then go over some specific instruments that could fall within those categories. There's a lot of content in these slides, so I'm going to move pretty quickly, but Rana will be sending them out to you. So if you want to dig further into the details or want to get some of the links or the references, just look out for those slides, because there's a lot of really good stuff in here. So to start this conversation of what we're talking about in regards to screening and assessment, I think it's helpful to think about our past as substance use disorder providers. So this comes from some of the ASAM literature, which says that historically what we've done is we've either looked at what's called complication-driven approaches or problem-driven approaches, which is essentially where we tend to catch patients and treat patients when they're highly symptomatic, right? That they're sort of in this cycle where they present to a program or to a provider because they're experiencing an exacerbation of symptoms. And this is true with a lot of diagnoses. As soon as we see a reduction in those symptoms, then we discharge them from care, and we don't see them again unless there's a relapse. So they're sort of in a treatment and relapse fluctuation. And that is not the most helpful way to treat substance use disorder or to really treat any chronic condition. So chronic conditions actually do much better when we use a client-directed or outcome-directed treatment approach, which really says that we should have a continuum of care, that patients can step up or step down their needs, but remain in some level of treatment with a provider or with a system of care throughout the course of their life, because that condition is going to be chronic. It's going to have multiple biopsychosocial dimensions that are going to need to be treated at different points in time. So really thinking about this as, rather than they move in and out of care, they stay in care, but they move up and down a continuum. So thinking about how you structure your work with patients based on episodes of care along that continuum is really the gold standard recommendation at this point in time. So thinking about, we may have more intensive episodes of care where we're seeing them very frequently or for longer durations, or providing more intensive services. And then as they make improvements, we may shorten or extend out the time in between those visits or those contacts, or we may even shift them to a lower level of care or even a higher level of care, depending on where they're falling based on their symptomatology. And so when we think about assessment or screening strategies, we need a means to stratify where patients are falling so that way we can match our intervention to their level of need. So you can see that the vast majority of patients that are going to be crossing, especially a non-specialty center, so primary care, emergency room, those types of settings, the vast majority of people are going to fall into a low risk category. So this is where screening becomes that universal measure where we're really looking to catch patients before they need that higher level of care. And then as they move into risky, harmful, or dependent levels, they're much smaller percentages and are going to need different interventions and different frequency of intervention. And so using a screener, so this is showing you two different example screeners, the audit and the DAST, which I'm going to go over in a little more detail here in a minute, as examples that can quantify where a patient might fall. So using a universal screener as part of your overall assessment approach can be really helpful to stratify the population that you're working with and know what kinds of interventions do I need to provide for them. So one of those larger models, and I'm going to go over ASAM and SBIRT. One of those models is the ASAM criteria. And so this is a substance specific assessment program or strategy that New Mexico endorses. We are considered an ASAM state, which helps to define that continuum, that placement criteria. Where should a patient be and what types of services are they going to need? And it assesses based on 6 different placement dimensions: their intoxication withdrawal risk or where they're falling, biomedical conditions, emotional behavioral symptoms, treatment acceptance or resistance, so sort of that stage of change that they might be in, their relapse potential, and then the recovery environment that they're currently in and will need for maintained stability. And then that leads to a decision rule to sort of say where on that continuum is this patient falling, recognizing that patients are probably going to move up and down at different points in their life. The nice thing about ASAM is it actually lines up with our CPT codes. So it allows us in terms of how we do billing and coding to follow patients up and down that level, from all the way from early intervention to medically managed intensive inpatient services, and knowing that patients are probably going to cross this continuum at different levels of care. Now, when the research is very clear that using something like ASAM, this research comes from ASAM matching, that we better serve our patients when we do appropriate matches, that when we send somebody to a higher level of care or a lower level of care, when we're not using evidence to inform that decision, that the outcomes are not as good. So patients that are better matched, regardless of substance, so we're sending them to the right level of care at the right time, are going to do better. And that's also true with retention and treatment and even follow-up. So we see that if we match them correctly, they do better longer term. So in general, ASAM is a good model that has good face validity, reliability, and feasibility, and allows us to better predict what is the type of intervention and intensity of care that a patient is going to need at any given point in time. And it's something that can really guide an H&P or can guide the general assessments that we do to make sure that we're providing that accurate match in terms of recommendation to either keep them at the outpatient level, step them down to something like community or peer support, or step them up to something like IOP or residential services. SBIRT is another kind of overarching model that has been widely deployed and shown good evidence for settings like primary care or emergency rooms, where we're doing that universal screening. So that means that everybody that comes in the door gets a substance use standardized screening tool of some kind, because remember that the majority are going to fall into that sort of prevention category. And if they're falling into the prevention category, they're going to get a different intervention than the people that are falling into a risky or possibly in an abuse or dependence category, and they're going to get an immediate brief intervention. So at that session, they're going to have a motivation-based conversation with their provider that's going to discuss their risky use behavior and give them some direction on what do they need to do to come back, what's the next step, is there a necessary referral to specialty treatment. So SBIRT kind of all in one package gives you these 6 steps that you can provide to help determine which category a patient is falling into and what you do based on that category. I've given you a link to an app that you can even download that has the full SBIRT toolkit in it to walk you through how to use this model if you're not familiar with it. So it starts again with everybody at that initial encounter and at frequent encounter gets a SUD screening and ideally also sort of a mental health screening. And then that determines which category they fall into. If it's low risk, then you really don't need to do much other than continue to screen. Moderate risk, you might provide some psychoeducation. As they step up to moderate to high in dependency, that's when we're going to provide that brief intervention and then follow up to specialty care. So we talked about that everybody gets the universal screening. What does that mean? So screening really is something that should be given to everybody. That is not used for diagnosis. It's just used to help us determine, is there a problem? So they're sort of tend to be brief and can be applied with large populations of people to detect that entire spectrum of unhealthy behaviors that might catch if somebody needs further intervention. So screening really should occur at that initial encounter, or if you're only seeing them infrequently, once a month or less frequent than that, then you probably want to screen at every encounter. You can use it not just for substance use disorder, but also mental health concerns, suicide risk, those types of things should be screened at an ongoing level. And it can be used in a variety of settings. Oftentimes they're in electronic format, or they're self-assessments so that they can be done in the waiting room. And they can assist with determining that where do they fall on this continuum and how do I make sure that I'm making appropriate recommendations and treatment plans with my folks. That's slightly different than assessment. So screening goes to everybody. Screening comes first. And then if they fall into that moderate to high risk category, then we're going to follow it with a more involved assessment. So not everybody's going to get the assessment. But once they've screened positive, then we go into gathering much more information on their mental health, their substance use disorders. And that's where we're actually going to produce some diagnosing, looking at co-occurring disorders, looking at readiness for change or stage of change, and digging into that treatment plan that might be specific to their substance use. So screeners come in a variety of different types, and I'm going to go through some of the public domain screeners that are available and you don't have to pay any money for, that also have some good evidence to support. CAGE was one of the first screeners, and it's still used, although it's not widely used, and it's specific to alcohol. The nice thing about it is it does show how to determine a standard drink on the assessment. It's only 4 questions, and they have scoring for men or women. It's a yes or no, so it's really easy to do kind of a quick and dirty, does this person have an alcohol concern? The audit is much more widely used, particularly the audit 3. It stands for Alcohol Use Disorder Identification Test. And it was developed by the WHO to collect a little more information than what the CAGE does. Since the CAGE is binary, it's either yes or no. The audit actually gives us frequency and amount of their use. It also has different scoring by gender, and tells you what would be a concerning score versus this is something we're just going to monitor. It indicates if somebody's drinking at concerning levels. The main difference between the audit 3 and the full audit is just the audit 3 is the first 3 questions. So what's above the red line, that's the audit 3. So if they are no to all of these, they are not positive, or they're in that first category of never, you don't necessarily need to continue on. But if they're yes, you may want to give them the full audit because you're going to get a lot more information about the actual drinking concerns. Now, if you're working with individuals who aren't coming in for alcohol, we still very much recommend that you employ something like the CAGE or the audit, because we know that alcohol is still one of the most widely abused substances in the country, definitely in this state. And so even though they may not be seeking treatment for alcohol use, we still want to keep an eye on it. And so here at ASAP, everybody still gets an alcohol specific questionnaire in addition to screeners about their particular use. That's a drug of drug of choice, should I say. The DAST is another great instrument. It stands for Drug Abuse Screening Test. It comes in a 10-item version, a 20-item version. It also has an adult and an adolescent version. And this aligns with ASAM criteria. So if you're already using ASAM and you're familiar with that leveling, the score on the DAST will tell you, do they need a higher or lower level of care, or are they appropriate for outpatient based on the score that they're giving you. The other nice thing about the DAST is it's not asking about a specific drug in terms of its use frequency or duration. It's asking about consequences of their use. So this gives us a little more information in terms of how their functionality is, or what is truly impairing in regards to their use behavior. So the DAST is, it gives you a little more contextual information. Another one that's really great and gives us a lot of information about multiple substances. If you have a patient that's potentially using multiple substances, is the MN Assist. It stands for NIDA, Modified Alcohol Smoking and Substance Involvement Screening Test. You can give this in a paper form if you don't have access to like an iPad or doing this on the computer, but it is developed to be a web-based interactive tool. It also aligns with ASAM and SBIRT. So at the end of the NM Assist, not only does it give you the recommendations for what is the appropriate level of care, but it also gives some recommendations if you're following the SBIRT model in terms of that brief intervention. What's the conversation or the psychoeducation that you could provide to the patient right now based on their score? So it provides links to some of that brief intervention pieces. It has an initial 8 questions that evaluates 10 different substance classes, and then depending on how they respond, that triggers what happens next. So if they say no to the heroin, meth, THC questions, they're only going to get the ones for cocaine or alcohol, or vice versa. So it's a pretty involved assessment if they say yes to all of them, but then you get a lot of really good data in regards to their use behavior around all of those different substance classes. The clinician can complete it or the patient can complete it. And I've given you the link to the actual interactive tool. The cows and the SIWA are also fall into this category, and these can be used as symptom trackers. So not just to know where a patient is at the beginning of treatment. So are they at a place where we want to be starting them on a certain medication, or what level of withdrawal are they in? What is their risk at this point in time? But it's helpful to be able to track change over time. And I know a lot of the prescribers will implement the cows and the SIWA protocols regularly as part of the interventions that they're doing. And then lastly, because everything I've just shown you is by and large self-report, except for the cows and the SIWA, have some objective questions about symptoms. It is also recommended to regularly use UDMs or UDAs, because this gives us some objective information about a person's use behavior, keeping in mind that there are different detection windows for different substances. So each program or each provider has to be kind of thoughtful how they set up the frequency of that UDA to make sure that they're just generally monitoring when some problematic use might be popping up. And this is particularly helpful right now when we're concerned about things that patients aren't even aware that they're using, such as fentanyl. So being able to check and have that conversation with patients who may not even be aware that there's fentanyl in some of the substances that they're used to using. The other thing, other than substance use disorder screeners, are mental health screening instruments. And there are a number of publicly available mental health screening instruments that can give you information, again, not to be used for diagnosis necessarily, but to give us a picture on where a person is functioning and what are the problematic symptoms that might be on the table. One of the ones that I always recommend is getting some kind of quality of life instrument that you do regularly, like the DAST. If we're only looking at sort of the pathology or the problematic symptoms, we could be missing other areas that give life meaning, or other areas to have really meaningful conversations that we're missing. And doing a quality of life screener can give us some of that information. How are they functioning in their interpersonal relationships, with work, with community connections? Are there areas where they're really unhappy that may be making certain changes we could increase their motivation. We could increase the likelihood that they're going to be willing to change some of the stuff that we're working with on them in the service of that job or family member or romantic relationship. So doing some kind of a quality of life screener is always really helpful. And then following that up with other things that can look at a specific mood and or trauma conditions or functionality. So the PHQ-9 is really good for looking at low mood or depression symptoms. The GAD-7 gives us kind of a global view of if there's any anxiety or panic conditions on the table. The PC-PTSD is just a 5-question assessment to see, is there any potential PTSD stuff on the table? The HUDAS is a really good general functionality instrument. So it tells us, are they having any difficulty with their ADLs or in those areas? And then the QOL is another quality of life. If you don't like the WHO-QOL, it is a publicly available quality of life instrument. And this is a link on the SAMHSA page where you can get all of those instruments. Now, once you've completed screening, then you can move into comprehensive assessment. And most of you are familiar with these components because they're part of your H&P, or if you're non-prescriber, you do psychosocial history. You're used to asking for a lot of this information that helps you to develop a diagnosis and a treatment plan. One thing that I always like to point out that we tend to forget is the importance of doing collateral and chart review, and maybe even adding in some standard instruments or assessments to help give us a bigger picture than just asking questions and getting patient self-report. Some of our patients are not great historians, or they may have reasons that they don't feel comfortable or don't want to share a lot of information with us, and we could be missing a piece of the picture. So when you're doing a really thorough comprehensive assessment, getting a release of information to talk to someone in their life, to talk to someone who could give you a little more information about how they're functioning outside of your office is super, super helpful. And doing a thorough chart review to see what has been done before, especially if you can get records from where they've received care. And then this is a list of some of those standardized instruments. Some of these you do have to pay for. The Addiction Severity Index is a semi-structured interview that has some skip pieces, but it collects a tremendous amount of information that can be very, very helpful. If you use the PDF, which I've provided to you, it is free. But if you want to use the web-based tool, there's a subscription that you have to pay for the ASI. The Brief Symptom Inventory is another one that gives a lot of information about possible comorbid psychiatric conditions and overall psychological distress. That one also has a nominal fee that you have to pay for to get the subscription for it. The OTI is public domain. Even though it says opioid treatment index, it is not just for people with an opioid use disorder. You can use it with any substance use disorder. That was just the name where it was developed in England. But it assesses for every type of substance use disorder, general health, comorbid issues, criminality, and other high-risk behaviors. So the OTI is a helpful standardized instrument that can get at, how much at risk might my patient be. That can be very helpful. And then other instruments that can be good if you really are struggling to get a thorough history, using something like the timeline follow back or the Form 90 can be very helpful instruments. They are time intensive to get that information, but the way they walk the patient through using calendars and different things can get you a very, very good picture of a person's use behavior over time. That can be super, super helpful for developing that treatment plan. Okay, so I think I only went a little bit over.